First of all, I would like to thank the organizer for inviting me in this beautiful place. It's an honor to be with you today. Thank you, Katerina. Thank you, Sofia. And I changed slightly the title of my presentation to Respiratory Drive and Dyspnea. And we will go together on a journey toward understanding and managing dyspnea. And this is the definition of dyspnea. Dyspnea is a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. What is dyspnea? This is a nebulous definition, and I will try to clarify it as much as possible. Respiratory center, located in the brainstem, behaves like an oscillator. The sender accepts constant inputs from various sources, and these inputs should go through a gate which defines the breath timing. When the gate opens, nothing happens, there is no activity of the sender. When the gate closes, then we have the output. And when the gate opens, this output goes fast to baseline levels. It is important to realize that respiratory drive is not related only to inspiratory muscles, but also it relates to expiratory muscles. And therefore, respiratory drive is the sum of activity of the sender that goes to inspiratory muscles, the blue, but also the activity of the sender that goes to expiratory muscles, the red. And in order to quantitate respiratory drive, we use the rate of change of electrical activity toward the inspiratory and expiratory muscles. Respiratory drive, therefore, determines the electrical activity of respiratory muscles. Blue is inspiratory, red is expiratory. We don't have in every breath expiratory muscle activity, but under exercise, this is very important. And the electrical activity of the muscles determines muscle pressure, which, according to the equation of motion, determines mean inspiratory flow, and finally, tidal volume. And you can see, tidal volume is the sum of the volume due to contraction of inspiratory muscles, but also volume due to relaxation of expiratory muscles if contraction of expiratory muscle is able to decrease and expiratory lung volume below passive FRC. Under these circumstances, relaxation of expiratory muscles create inspiratory flow. Now, depending on respiratory rate, we have ventilation, and in this system, since the integrity of the pathway from respiratory sender to tidal volume generation is intact, normal, respiratory drive is satisfied by mean inspiratory flow. However, if the pathway is not intact, a dissociation between respiratory drive and mean inspiratory flow exists, and you can see at a given activity of the sender, if the pathway is intact, you can see the tidal volume, compare this tidal volume with the tidal volume when the pathway is not intact. And therefore, the rate of volume increase is less than the rate of brain activity increase. At this point, I would like to discuss with you two copies. One is the copy of output of respiratory sender, and the other is the copy of mean inspiratory flow. Both copies are projected to cerebral cortex, and then cerebral cortex compare these two copies, and the whole process is executed via a pathway. We call it corollary discharge. And dyspnea occurs when there is very high first copy, very high output from the sender, despite the fact that the second copy is similar to the first one. We all have experienced mild dyspnea during exercise because the first copy is very high. The problem is that if the first copy is high, but the second one is less than the first one, then dyspnea is increased. And in this schema, it is important to realize that chemical feedback plays a very crucial role, and chemical feedback is executed by two gases. One is CO2 and the other is oxygen, but oxygen is a very weak direct modulator of respiratory drive and ventilation, and therefore CO2 is the important gas. And indeed, hypoxia affects the sender not directly, but by changing CO2 sensitivity. Low PO2 increases CO2 sensitivity. This is the well-known metabolic hyperbola, which is the graphical representation of alveolar gas equation for CO2, a negative feedback system. If in this room you are going to hyperventilate, you will decrease PCO2. If you hypoventilate, you will increase PCO2. And PCO2 depends on CO2 production, but also depends on the ratio between dead space and tidal volume per breath. In humans, we have another system which is positive feedback system. If I give you CO2, you will hyperventilate. And this system depends on what we call ventilatory response to CO2. During steady state, the intersection point between the curves of these two systems defines the eupneic PCO2. Also, it is important to understand that these two curves change position. If we increase dead space tidal volume ratio or CO2 production, metabolic hyperbola moves upward. If we decrease, metabolic hyperbola moves downward. Hypoxia, metabolic acidosis, and stimulation of various receptors, mainly in the lung, moves the ventilatory response curve to the left. Metabolic alkalosis, sedation, and various hypoventilation syndrome moves this curve to the right. Having said this now, let's follow the respiratory drive of an adult human from health to acute and chronic disease. And I'm going to use some examples. Acute disease, I will use the examples of pneumonia. Chronic disease, I will use pulmonary hypertension, important, interstitial lung disease, and COPD. Not acute decompensation, but chronic. The whole presentation is based on three papers that we published relatively recently. And in the first paper, published in 2020 as a state-of-the-art in blue, for the first time in the literature, we introduced two new concepts. The concept of brain curve and the concept of ventilation curve. The whole approach has been accepted by scientific community, and now the paper has approximately 320 citations. Okay, we have a normal human. This is the metabolic hyperbola, and this is the ventilatory response to CO2, but when respiratory drive, brain output, is satisfied by ventilation. This is a theoretical curve, and we call this curve, again, is theoretical curve, brain curve. Brain curve is the CO2 sensitivity of the respiratory sender, or in other words, the desired ventilation for a given PCO2. In normal humans, the desired ventilation is similar to actual ventilation. Actual ventilatory response to CO2 under normal condition, we call this ventilatory response to CO2 curve ventilation curve. And this is not theoretical, it's actual, because we can measure ventilation. In normal humans, ventilation curve is the same with brain curve, and the intersection point between the metabolic hyperbola and ventilation curve defines PCO2. In this case, PCO2 is 39.5, and minute ventilation is 6.5 liters per minute. Output from respiratory sender corresponds to 6.5 liters per minute, muscle activity corresponds to 6.5 liters per minute, and actual ventilation is 6.5 liters per minute. Respiratory drive is satisfied by mean inspiratory flow. We have two copies, relatively small, and these copies are equal. And this is the reason why we don't think about active breathing. I mean, in this room, nobody is thinking breathing because the first copy is small and the second copy is similar to the first one. This human now develops pneumonia, and we know that pneumonia increases elastance of respiratory system. Because of that, the problem in pathway is located in the equation of motion. Elastance is higher, and therefore at a given electrical activity of respiratory center, tidal volume is less. You can see the tidal volume if the pathway is intact, okay? And the tidal volume if the pathway is not intact at the level of equation of motion. Now, for a given level of respiratory center activity, ventilation is reduced, and therefore we have a deviation between these two curves. The new PCO2 is at the yellow point because always PCO2 is the intersection between ventilatory curve and metabolic hyperbola, 40.5, slightly higher than before. This corresponds to 6.2 liters per minute. But for the brain, this is hypercapnia. And now brain increases its activity, and the activity from the brain corresponds to 9.2 liters per minute. Muscle activity is for 9.2 liters per minute, but actual ventilation is only 6.2 liters per minute, so we have a deficit of 3 liters per minute, two copies different. The first one is higher, is larger than the second one. Because the deficit is not very high, dyspnea is mild. In any case, this patient is going to think that something is wrong with my breathing, but dyspnea is not very high. The problem is if pneumonia is getting worse, and then we know that severe pneumonia is associated with severe hypoxemia, very high activity of receptors in the lung and chest wall, and finally, if the patient has sepsis, we may have metabolic acidosis. And all this shifts brain curve to lower PCO2, while its slope increases, and therefore we have an increased CO2 sensitivity of respiratory center. This is the normal, and this is with severe pneumonia. You can see now the desired PCO2 of respiratory center is around 26 millimeters of mercury. At the same time, elastance is very high because you can see the X-ray, and for this reason we have greater deviation of ventilation curve from brain curve. So, from one hand, we have an increased CO2 sensitivity, brain. On the other hand, we have a reduction of ventilation at a given respiratory center activity. Now, this is the deviation. The new PCO2 is 29 millimeters of mercury. Minute ventilation is 9 liters per minute. We believe that this patient has hypocapnia. This is wrong because the brain feels that is severe hypercapnia, and therefore the brain increases its activity. And now the brain activity corresponds to 31 liters per minute. You can see a patient with severe pneumonia in emergency department, they are not able to finish a sentence. They have diaphoresis, they have accessory muscle contraction. It's similar to when we are doing heavy exercise. And now we have two copies. The first one is 31 liters per minute. The second is only 9 liters per minute. So dyspnea is increased. And finally, because we didn't finish yet, we have to discuss about metabolic hyperbola. If the patient has fever, we will have an increased CO2 production, and always with severe pneumonia we have inefficiency of gas exchange, and therefore dead space increases. Both moves upward, metabolic hyperbola, and look what is going to happen. New intersection point, actual PCO2 is 32, we believe is hypocapnia, and brain activity increases to 44 liters per minute. And muscle pressure increases to 44 liters per minute, and therefore we have a very large first copy and very small relative to the first copy, second copy. Dyspnea is severe, and in a awake patient, this increase in dyspnea may elicit tachypneic behavioral response, panic reaction, or in some patients, delirium. And further increase in frequency decreases tidal volume because of dynamic hyperinflation and increases dead space to tidal volume ratio, and this is the well-known rapid shallow breathing pattern. Metabolic hyperbola moves further upward, new intersection point, very high brain activity, similar to heavy exercise. This patient should be intubated because this patient is at risk of patient self-inflicted lung injury. I'm not going to touch this issue. Now, let's move to chronic disease. And I will start from patients with pulmonary hypertension. The main symptom of from a patient with pulmonary hypertension is dyspnea on exertion, and this is the symptom that decreases a lot the quality of life. And this is a typical cardiopulmonary exercise test in a patient with pulmonary hypertension. You can see at the end of exercise, work rate is very low, approximately 40 watts, and oxygen consumption is also very low, approximately 520 ml per minute, when the normal is approximately 1,500 ml per minute. And you can see at the end of exercise, we have huge ventilatory reserve. This patient has maximum voluntary ventilation around 92 liters per minute, based on spirometry, and at the end of exercise, this patient had only 34 liters per minute. So they had very large ventilatory reserve, and he or she didn't reach maximum heart rate. And you can see also the slope between CO2 production and minute ventilation is very high. Normally is less than 30. They interpreted this result first saying that the patient stopped exercise with large ventilatory reserves, reflecting the predominance of cardiovascular mechanisms. And therefore, respiratory system is not responsible for exercise limitation. This is totally wrong, although it is written, but it's wrong. Why it is wrong? Because the patient reported that severe dyspnea was the symptom that forced her to stop exercise. And let's see at this point the effects of pulmonary hypertension on these three curves: brain, ventilation, and metabolic hyperbola. In patients with pulmonary hypertension, group 1 or 4, it applies to every group, but for simplicity, I choose to discuss only clear group without comorbidities. And by multiple mechanisms related to the disease, in patients with pulmonary hypertension, brain curve is shifted to lower PCO2. Therefore, we have high CO2 sensitivity of respiratory center. This is the reason why patients with pulmonary hypertension are hypocapnic. Not only that, but hypocapnia is a predictive factor for high mortality. At the same time, these patients have weak muscles, and also they have high airway resistance due to disease. And because of these two problems. During exercise, even during mild exercise, they develop dynamic hyperinflation, and therefore we have deviation of ventilation curve from brain curve. So we have the same problem as pneumonia. High CO2 sensitivity, lower actual ventilation. And finally, during exercise, always we are going to increase CO2 production, but in pulmonary hypertension patients, there is inefficient gas exchange. The lungs are not working very well, and therefore always there is an upward shift of metabolic hyperbola. Not only that, but due to right heart dysfunction, this patient goes relatively early to anaerobic threshold, and therefore we have metabolic acidosis. Metabolic acidosis further moves the brain curve to lower PCO2, and at the same time, due to high ventilatory demands, increases dynamic hyperinflation. In this paper, and in this particular patients that we have already discussed, we use a complicated analytical model. It is not the right time to discuss it. And we calculated the respiratory center desired ventilation at the end of exercise. And we found that respiratory drive of this patient corresponds to 90 liters per minute. So it's maximum. It cannot go higher than that. And therefore, receive only 34 from 90. Dyspnea is very high, and because dyspnea is very high, the patient stop exercising before reaching maximum heart rate, which is the limiting factor in every patient, including patients with pulmonary hypertension. And these are data of Sun et al. That we reanalyzed, and we saw that in patients with pulmonary hypertension, at the end of exercise, ventilatory reserve increases and heart rate decreases as disease severity worsens. So, by interpreting the results as saying that respiratory system is not responsible, it's totally wrong. Let's move now to see the other two categories of patients with chronic disease, interstitial lung disease and COPD. Very important paper published by the group of Dennis O'Donnell, and you can see here the relationship between work rate and respiratory drive. In this study, they estimated respiratory drive using EMG of the diaphragm. And they related EMG of the diaphragm during the one breath to maximum. And they found that at the end of exercise, the black is COPD, the red is interstitial lung disease. At the end of exercise, in both groups, respiratory drive was 70% of maximum, having a work rate only of 80 watts, very low. And the blue is normal. You can see at the same work rate of 80 watts, normal has 20% of maximum drive. At the end of exercise, normal achieve approximately 180 watts, very high work rate, and they had only 60% of maximum respiratory drive. And here you can see the relationship between respiratory drive and minute ventilation in the three groups. At the end of exercise, minute ventilation in both groups, COPD and interstitial lung disease, was 55 liters per minute. At the same 80 watts, normal had only 35 liters per minute. The drive, when at the end of exercise, in normal people, maximum ventilation was close to 100 liters per minute, and this is the drive, okay? But look what is happening in the drive of COPD and interstitial lung disease. You can see that the drive was 70% of maximum, and therefore was 10% higher than the corresponding drive of normals. Taking into account this, we calculated that at 80 watts, patients with COPD or interstitial lung disease, they had output from the center that corresponds to more than 100 liters per minute. So extremely high drive. They receive only 55 liters per minute. Dyspnea is very high, while in normal people at 80 watts, drive was 35 liters per minute and minute ventilation was 35 liters per minute. So to summarize, the pathway leading to dyspnea, acute or chronic, always involves alteration in brain curve, ventilation curve, and metabolic hyperbola. The message is that the respiratory system is the major determinant of dyspnea. And at this point, I would like to give you a take-home message when you have a patient complaining of dyspnea, because the patient wants from you a relief of this symptom that reduces a lot the quality of life. I think it is important to think three questions. The first question is there a leftward shift of the brain curve? If the answer is yes, you must do something to decrease CO2 sensitivity. We don't have medication other than opioids, but I think the problem is that we don't push the industry to produce drugs that decreases CO2 sensitivity. We have only opioids, and several studies have shown that opioids decreases dyspnea in patients, but as you can imagine, it is not easy to prescribe opioids for a long term. Of course, if you are able to improve the pathology of the lungs and chest wall, you are going to decrease CO2 sensitivity, and of course, correct other causes of high drive, metabolic acidosis, and of course, hypoxemia. The second question is there a deviation between brain and ventilation curve? This is very common, okay? And the answer, the solution is to restore the integrity of the pathway from the respiratory center to tidal volume generation. Not an easy task, but you have to know all the pathway in order to react. And finally, the last question, is there an upward shift of metabolic hyperbola? If yes, you must decrease metabolic hyperbola. First of all, decrease the ratio dead space to tidal volume. Not easy, because you have to take action on vacuum, dismatch, sand through the space. And also you must decrease CO2 production. Obesity is very important, because obesity is associated with high CO2 production, but also it is very important to exclude diseases that are associated with high CO2 production, such as hyperthyroidism. And finishing my talk, this is my last slide, and it is sad that we don't take into account dyspnea for these patients. And we don't take into account dyspnea for these patients because basically we don't know about the pathway of dyspnea. Dyspnea has nothing to do with the heart function. Heart function may increase dyspnea, but through changes in the three curves. Okay? Thank you very much for your attention.